Khan, and I'm working as an assistant professor of medicine at Medical Unit 3. Um, as you all are aware that we are going to have a series of lectures on radiology, essentials of radiology for residents in the Department of Medicine. I think this is going to be really useful course for you. And for that, I have requested Dr. Zishan Sipra. Dr. Zishan is a graduate of King Edward Medical University. He has been a very brilliant and outstanding medical graduate. And then he started his residency training in radiology at Shaukat Khanum Medical Research Hospital. And so I had requested him to give a number of talks. So here he is. So without any delay, I would request Dr. Zishan to present and enlighten us with the first lecture of the series. And as you can see, this is the first lecture is on chest X-rays. I think we will have a series of lectures on computed tomographies, CT scan, MRIs. But I think the most common investigation that we obtain is a chest X-ray. So over to you, Dr. Zishan.
Thanks a lot. So, as Dr. Zaman said, I'm Dr. Zishan Sipra from Shaukat Khanum. I'm here in final year of my residency, almost completing that. So, before proceeding, I hope that most of you are from medicine, and most of the time we need chest X-ray to evaluate usually the pulmonary findings, sometimes the cardiac findings, and sometimes ancillary, for example, the air under the diaphragm, or sometimes mediastinal adenopathy as well. If we know the anatomy, that's the key to actually accurate diagnosis and interpretation of the chest X-ray. So uh, this slide appears to be the basic of rather uh, any radiograph, rather CT scan. So relative density, the concept is which material appears as dense, that's white, and the material which is less dense, for example air, that appears black on an X-ray. Uh, as you can see, gas, air in the lungs, that should be black. Fat is very less dense. It appears black on X-ray. For example, knee fat on a knee radiograph. And water has uh, intermediate density. It should not be as white as that of bone, but not like black as of air. So these are gradually increasing densities: gas, fat, water, bone, and metal. So the most dense material is metal, then is the bone. Now, the quality of radiograph, I hope so. It should not be in your challenge, but remain. I feel that everybody of you know that it should be obtained in inspiration, in rather at the depth of inspiration. When we have a shallow inspiration, that appears as a low volume lung, and it mimics pathologies. Although most of the time in ICU settings, or when the patient is bedbound and critically sick, is unable to inspire that much, but we should be able to interpret the normal anatomy first. So that is actually on a full inspiration radiograph. And the penetration and rotation that I'll cover later on, these are regarding the quality of radiograph. Inspiration. Uh, so this is the first image you are looking at. It's a normal chest radiograph. It is for you to understand what is full inspiration. Basically, the shadows over here, these are depicting the anatomy that is overlying the chest. So, for inspiration purpose, I'm starting with the anatomy of the ribs. I hope so you can appreciate these are the ribs as we all appreciate. But most importantly, the radiologist is counting not this posterior part of the rib. I'm drawing for you the first rib over here. This is going like this. So it starts over here, it goes round like this. Then the second rib, it goes over here, it goes round like this. And the third rib, it goes like this and comes over here, anterior. This oblique part, this is the anterior part of the rib, and this horizontally looking part, that is the posterior part of the rib. As we can appreciate the rib cage, the anterior part, that is downward inferior slanting ribs of the bilaterally. So a good quality radiograph must have ideally should have 8 ribs above it, anterior ribs, 1, 2, 3, 4, 5, 6, 7, and 8 ribs above this diaphragm crease before above this level of diaphragm. So it's a good quality inspiration, it's good quality radiograph. Further, I'll move on. Penetration. The penetration rule, obviously, normal radiograph must have, I hope so you can appreciate there are vertebra behind this shadow of the mediastinum. We can count these vertebra, rather. We can count it as different. This is another vertebra, this is another vertebra. If a radiograph was adequately penetrating the radiograph rays, the radiographic rays, actually chest x-rays that were penetrating enough that it passed through the heart, so it can make the vertebra behind the heart shadow also visible. It should be barely visible, not truly visible, because if we penetrate it too much, these lung markings also become poorly differentiated. But obviously, one take home point would be that if we can appreciate this spine behind the heart, it should be a good quality radiograph. It would help to delineate the vascular markings as well over here. So underexposure is actually for a layman, it's a white film that is underexposed. So, for example, over here, we cannot appreciate the spine over here. It's not penetrated. Overexposure. Overexposure is a black film. For example, this. Overexposure, the heart is rather gone, the spine is rather more visible, and the uh, drawback of this overexposure is that the lung markings have also gone. They have also turned black. So it is an overexposure film. For rotation, it's important in an ICU setting. For example, this patient, this is a true PA view radiograph. This is also a PA view, but there is rotation of the mediastinum. For mediastinum, I would request you to appreciate as, इसे यूं ही समझें जैसे एक दीवार है जो सीधी सेंटर में खड़ी हुई है. अगर दीवार को आप एक साइड से देखें तो वो पतली लंबी नज़र आती है, जिस तरह की ऐसे. लेकिन इसी दीवार को अगर आप रोटेट कर दें, ये दीवार इतनी बड़ी है, यहाँ से लेके यहाँ तक. तो क्या हुआ है, दिस एक्चुअली appears as a widened mediastinum, but is actually this is not a mediastinal widening, it is a normal uh, mediastinum. This is due to rotation. The rotation can be actually easily judged by looking at the clavicles. Ideally, the end medial end of the clavicle, this is the clavicle, this is the left, this is the right clavicle, collarbone. So both clavicles are at the borders of the spine, medial ends. If anyone is crossing the midline, for example, over here, it is over the spine, but this uh, right clavicle is quite away from the spine. So this shows that this radiograph was in rotation. For rotation, a single rule is that we can comment on the lungs, but this center of the image, which includes the heart, the great vessels, and the mediastinum, we actually cannot reliably comment on that. And similarly on the mediastinal shift as well. Hmm. So I hope so. The common view we obtain is the posterior anterior view, PA view radiograph. Lateral view, the usual purpose of lateral radiograph is to look at the small pleural effusion. And AP radiograph is actually in bed-bound patients where we cannot obtain a PA view, so we can have an AP view anteroposterior. Uh, this is a PA radiograph. I would, for lateral radiograph, I hope everybody can appreciate this. Lateral radiograph, we can appreciate actually both lungs at the same time. We'll cover it later. And the spine is rather better visualized on the lateral view. Okay. So starting off this is the right oblique fissure and horizontal fissure of the right lung. I hope most of us know. If others not, then I can relate to you that the right lung has three lobes, while the left lung has two lobes. So this is the right lung. Right lung has an oblique fissure, like left lung. This goes like this. This is an oblique fissure, but it also has an horizontal fissure, which divides this upper lobe into the upper lobe and middle lobe. Actually, for the left lung, whole of this part of lung above the oblique fissure is the upper lobe, while posterior to this oblique fissure, that's the lower lobe, and it's rather oblique. The right lower lobe, even the part is quite above the nipple level as well over here, for example, and the part of upper lobe is quite below the nipple level over here as well. But on the right side, we have a middle lobe as well. So middle lobe projects in rather lower area, and in anterior to the right lower lobe. I would this is lateral radiograph. It has actually superimposition of both lungs. So roughly the oblique fissures overlap. For I hope so for medicine, as it would be more than required to know, to appreciate rather of fissures. But this is roughly the areas, the pathology. Where should it be? It should be in the upper lobe. It should be in the lower lobe. This opacity could be in the right middle lobe, but we can correlate with the PA view as well. Retrosternal space, I hope so. It should be clear space. The retrocardiac space, that is a clear space. Any airspace or fluid in this area, that's pathological. So I hope maybe you are interested in knowing the great vessels, how we judge them. The descending thoracic aorta, that's better evaluated on the lateral radiograph than a PA view. But just showing you the lateral radiograph anatomy first. Aortic knob. Aortic knob. This would make a knuckle on the PA view. What is knuckle? It is a rounded shadow of whole of the aortic arch. So this thoracic aorta, this is descending in the lateral radiograph. It is originating like this in the arch. It originates anterior and goes obliquely posterior. On the lateral radiograph, it forms a true arch over here like this. Uh, so I would like to move on with the lateral view. So right ventricle is over here. Regarding inferior vena cava, the inferior vena cava, that's actually the part of the heart that is touching the diaphragm. That's actually inferior vena cava. roughly that was the posterior border, ventricle and atrium. I would move with the AP view. AP view, this is the view we obtain usually in a ICU setting. For example, we can appreciate these are the chest leads. There are the sternotomy sutures over here that suggest this patient had an open heart surgery. And we can appreciate, we cannot really comment on the center of the image. This is the heart actually. Uh, the recommended guidelines for reporting radiographs say guide that we should not comment much on the heart size on the AP view, and we can better appreciate on the PA view. Uh, Massive cardiomegaly is another thing that we can see the heart shadow going beyond 2/3 of the image. But the rule of thumb for a PA view would be half of the image if that's the size of the heart. For example, transfer size from here to this border of the heart, if it takes more than half of this chest whole transverse diameter of the chest, then it's cardiomegaly. I'll touch the pathologies and how to interpret that later on. Lateral decubitus, I hope so. We usually don't need that, but to complete the projections acquired in radiography of the chest. So, this lateral radiograph is usually acquired in such a patient which cannot lie erect for air, for example, pneumothorax, and also to document if there is pleural effusion, for example, like this, with an air fluid level. It's especially important in few cases of foreign body inhalation and in pneumothorax specifically. Okay, I hope so. Anatomical structures in the chest, you all know mediastinum, the hilum of both lungs, and then the lung fields, and then the bones, and then the soft tissue. This is rather the reporting template, how we follow it. We start from the centum, first mediastinum, both hila, then the lung fields, then the diaphragm, so we'll start with the mediastinum. We'll go to the lung hila over here. These are both lung hila. Then we appreciate these are the lung fields. These are the zones. This is the upper zone, this is the middle zone, and this is the lower zone. Then we see this is the diaphragm, the dooms of the diaphragm, and these are the pleural surfaces. Pleural surface over here, that's important, and then pleural surface over here, that's important. And then we look at the bones. We can appreciate the ribs if any fracture is there, and then the soft tissues outside the chest. So regarding the anatomy of the mediastinum, I shared with you earlier. So we can actually what we see on a normal mediastinum. I hope so everybody of you can appreciate this is trachea. uh, Let me share trachea. So the trachea should be centrally located and slightly to the right. Okay? Aortic arch, and then pulmonary artery and the lateral margin of the superior vena cava. For example, superior vena cava over here. This is actually the lateral margin of the superior vena cava. The ascending aorta is over here. It's rather difficult to appreciate, but I will tell you the aortic arch would be easily visible. So this is the right atrium. I am going from the right side. So this is the inferior vena cava. Now the vessels of the aortic arch actually. So this is the aortic arch. It is also called the aortic knuckle. It is rather easy to see on all radiographs, and it's very important landmark to comment on the mediastinum where the pathology lies. Is it above the arch? Is it below the arch? And these are the vessels where we appreciate these are the borders of the mediastinum where we comment actually on the mediastinal widening. This was central was the trachea actually. So again, this is the ascending aorta. So aortic arch that actually goes round like this. It comes from anterior to posterior. It goes back actually. The aortic root is over here. Uh, aortic root is over here. It ascends up and goes behind like this. So it would start from here, goes above and behind. This part is actually superimposition of the arch that forms a knuckle over here in the radiograph. It is called aortic knuckle, and then it goes down over here. This border, this is a dense shadow of the descending aorta. Pulmonary artery, I would cover this as the left side, and this is the left atrium, and the later is the left ventricle. I hope so you everybody can appreciate this anatomy now. So this was the parts of the mediastinum. Okay, CP angle, costophrenic sulci recesses. So these are very important. We appreciate actually, for example, these crisp triangular angles. These are very important to comment on pleural effusion. Whenever we see blunting over here, loss of this blackness that is actually filled with fluid, haziness over here even, that suggests underlying effusion. If the patient is actually erect, then it would form a meniscus. For example, it would form a water level here. If the patient is flat, in these angles, poor loss of infusion over here. And there are also, these are CP angle, cardiac
Uh,
angles. These are also recesses.
sorry, Dr. Zishan, can you please repeat these things? I think there was some interruption in the connectivity. So I think if you can just
Okay.
comment, repeat the last thing that you said on the, yeah.
Okay, okay. I'm showing you these are the CP angles. These are actually important to comment on the pleural effusion on a peer radiograph. So most of the time patient is erect, so we can see actually a level of fluid. The blunting of the angle is quite crisp. We can see that this angle as compared to the other that shows blunting, there's no beaking in that angle. But in case of AP radiograph, when a patient is supine, is bed bound, the film is acquired by placing the cassette behind his chest in an AP view. This fluid level would not be seen, but we can see haziness over here. So ideally, it should be like this. This should be black like this, and crisp and beaking should be appreciated. But even haziness in a AP view, which is a ICU setting, or fluid level in a erect posture, that suggests effusion. And rather, if there is slight blunting, even the size in few centimeters, that is rather near 300 milliliters of effusion, because this PA radiograph is quite less sensitive as compared to the lateral radiograph to detect pleural effusion. So cardiophrenic angles not that much important, but just to complete the anatomy, this is the left side. This is the left lung's anterior border. This is the right lung's anterior border with the heart, making the cardiophrenic angle. Okay, uh, this was the horizontal fissure. Okay, the heart. Okay, everybody knows the heart silhouette. Heart silhouette, its size, shape. These are the important diameters to be checked in the heart. I feel if Dr. Zaman can recommend further, I would complete the mediastinum this time, and we'll go to the lungs next time, because I feel the class should be a shorter one, so that people can have it completely understood and absorbable.
I totally agree with that, Dr. Zishan. So I think we can split it into settings. So today we can discuss mediastinum. I think it's very important because in medicine we rely a lot on chest X-rays for making the usual diagnosis. So I agree with that.
Okay, so proceeding. So before I show you how to appreciate rather size and the shape, the sill head, what does that mean? I'll come to that, and the diameter of the heart. So briefly, you need to see these four parameters in the heart shadow. So coming on the size first, there's a point that actually makes it easier to remember, that heart size on an AP radiograph appears larger than it actually is. So I would rather recommend you to remember what should be the size. For the size, this is the cardiothoracic ratio. Cardiothoracic ratio is actually the transverse ratio from one uh, border of the lung to the other. This is the cardiothoracic ratio. At max, for any heart, it should not be more than 50% of this diameter. So, when the heart size is more than 50% in a PA radiograph, erect PA view of the chest, then we can reliably predict that there is cardiomegaly, and echocardiography should be advised or either performed to evaluate the cardiomegaly and the causes related to that. But in any case, the one third of the heart is on the right if it's true non-rotated radiograph, then, and two-thirds is on the left. uh, I would like you to appreciate the previous uh, anatomical figures which make the right heart border. I feel you will have remembered that over here this was the actually part of the arch of aorta, ascending aorta, and over here this was actually the right atrium. Mainly the right heart border is formed by the right atrium, not the right ventricle actually. And the base on the right side, this is actually formed by the inferior vena cava, which opens into the right atrium. So the right ventricle is actually lying behind this heart shadow over here. So the border of the heart, if we see a bulge over here, so that may be a sign of right atrial enlargement, for example. On the left heart border, I hope you remember this was the aortic knuckle over above, and this actually part, this is another knuckle over here. This is actually part of pulmonary trunk opening into the left atrium. Pulmonary trunk, that actually is the pulmonary arterial system. Sorry, the venous channels are over here. These are coming to the left heart over here. These are the pulmonary arteries and veins. Pulmonary trunk is actually the arterial system. Pulmonary arterial trunk, that is the outflow track of the right ventricle. This is also producing a knuckle, and this distance between the aortic knuckle and the pulmonary knuckle, this is called the AP window. This actually helps a lot in checking mediastinal lymphadenopathy. Usually, lymph nodes fill up this concavity, and this becomes straightened like a straight left heart border. That actually suggests that either the pulmonary trunk that has increased in size, filling up the space, or more commonly, there is a lymph node that is producing a shadow and filling up the space. Just to complete the heart shape, so this lower part is actually the left, ventricle. And when we see, usually most of the time we see cardiomegaly, there is more increased size of the ventricle, ventricular left ventricular enlargement. So this part of the heart that actually enlarges, and we see rather a flattened heart. The transverse diameter of the heart then goes beyond the 50% size of the cardiothoracic diameter. Regarding silhouette, I hope going back, what is silhouette? Silhouette is actually appreciation of a border. When we see a border, this is a silhouette. Silhouette is an overlap of two materials of different density. For example, the lung, this is an air containing viscous, which is quite less dense, and heart, which is a muscular organ that is quite dense as compared to the lung. So whenever there is an interface between two such tissues which are in different densities, we can appreciate that there is uh, silhouette formation. And silhouettes are very important. Why important? Because we see actually the loss of silhouette is a sign of increase in density of the lung. The silhouette is actually important for the lung. So in cases where uh, there is a airspace disease, there is a consolidation, this border of the heart that actually disappears. So we say there is loss of right heart border. There is silhouetting of the right heart border. This silhouette of the right heart border is lost. And all of these terms actually depict that there is a pathology going on in the part of the lung adjacent to the right heart. And similarly, when there is silhouetting of the left heart border, it means there is actually loss of left heart border. We cannot appreciate. Similarly, there is silhouetting over here as well. There is a diaphragm appreciable behind the heart shadow, even. We can appreciate there is a less dense lung as compared to the diaphragm as well as the abdominal organs. So the lung is producing a silhouette at the diaphragm with the abdominal organs as well. When this silhouette is lost, it also says that it could be a retrocardiac left lung pathology. It could be a consolidation behind the heart. So this is regarding the silhouette of the heart. So, and last, we already covered diameter. So I feel we'll move to the hilum in our next session, inshallah. And then I'll cover the lung zones as well as the vascular markings. And I would rather stay to let you actually appreciate different types of pulmonary edema in the next session. Will rather be covering few pathologies related to the lung, because the anatomy of the lungs is quite short. There's not much left to be covered regarding the anatomy. So the hyla are important for pathologists, so we'll include that in the evaluation of the lungs. I hope, as you agree, Dr. Zaman.
Uh, okay, so um, is that all for today, Dr. Zishan?
I feel if you all agree, uh, I feel it should be sufficient for the first time. Could be an introductory even. I feel most of you might even already know all this stuff. I could jump to the pathologies, but for me, there is really very importance given to these anatomical parts which I showed you today regarding the mediastinum, the borders of the heart, and then I'll actually move on in the next session to the pathologies, because I feel most of the colleagues over here would be interesting more in different uh, cases where we can appreciate what the pathology is. It would make rather it more interesting. What do you say?
Okay, right. So this is my understanding that in next session, we will look into various types of abnormal radiographs with a number of mediastinal abnormalities as well as abnormalities in the lung. Is that true?
Yes. Mainly, I'll be showing you different pictures of pathologies which are, for example, affecting both lungs and heart or the mediastinum. A complete case where we can appreciate what are the findings in that radiograph. And because case based would be rather good, but I would be systematic initially, then we'll do
Okay.
it wholesome, inshallah.
Okay, right. So uh, thank you very much for this introductory talk on chest radiography, and I hope it would be useful for everyone here. Um, so now I would move to questions. So if there are any questions, you can unmute yourself and ask those questions, please. Uh, Feel free to ask those questions. We can stop the recording now, and maybe our resident would be more comfortable with that if we can just discontinue the recording and then proceed with the questions.